long ago.
I was on your itinerary.
Good to see you. And thanks for having Lalitha. She's going to do a great job.
My pleasure.
Thank
Our
you.
pleasure to have her as a speaker.
Thank you, sir.
Okay. So welcome everyone to the speaker exchange program that we have between Johns Hopkins Hospital and Brigham and Women's and the Harvard Health System. We're privileged today to have Lalitha Sundararaman as our speaker. And Lalitha comes to us initially by way of the Tamil Nadu region in the southeast portion of India. She came to Miami to do anesthesia residency in 2008. She did a fellowship in transplant. She came to Brigham and Women's in about 2013, joined the Harvard Health System, where she's now on faculty. She's on multiple ASA committees. She's on the editorial board for the ASA newsletter, which you know is now called the ASA Monitor. And Lalitha has a special interest in procedures outside of the OR, where we know our skills are in high demand. She is committed to allopathic, Ayurvedic, and acupuncture techniques for women's health and pain management. And one more thing, I looked up Ayurvedic because I wanted to see what that was. And it's a 3,000-year-old whole body healing belief of health and wellness, which achieves pain control through balance between mind, body, and spirit. So with that, Lalitha, I'll let you take over, and hopefully we'll have time for questions. And welcome as our speaker.
Thank you, Steve, for that lovely introduction. I'm privileged to have the opportunity today to speak on anesthesia for endoscopic bariatric surgery. This is kind of an upcoming field, and we have the opportunity to practice it extensively at the Brigham, and we've developed quite an experience in it. And I have the wonderful opportunity to help share this experience and probably facilitate its growth outside as well. So why is bariatric endoscopy on the rise? Why do we even have to give it a second look? Well, obesity has really tripled. And while 13% of the world's adult population is now classified as being obese, but actually the criteria are a little bit broader in the sense that in many Southeast Asian and Asian countries, the cutoff is less than the conventional 30. And actually, if you see, the number is closer to a terrifying 30%. So something has to be done about this epidemic. And it's not only Michelle Obama who is worried about it. All of us should be. Obesity treatment needs a lot of things. First and most important is acceptance of the fact and behavioral modifications, including diet, exercise, and of course, supplemented with pharmacological therapy, as well as bariatric endoscopic weight loss. It could be bariatric surgery or endoscopic weight loss. Now, it has been well established that the most effective and durable method of perpetual weight loss would be bariatric surgery. But many people are scared of surgery. Many people are scared of going under the knife. So is there a viable alternative? And one of that would be bariatric endoscopy. Less invasive with similar results. That could be a game changer. So immediately when you think of endoscopy, we just think like, oh, it's just endoscopy. Tell me, should I give MAC or should I give GA? Well, if I were a Shakespearean actor, I would say to intubate or not intubate. That is a question, but I'm not. I have to think a little bit deeper than that. So we have to think about the patient as a whole. When we consider the type of bariatric procedure, think about everything, pre-procedural concerns, intra-procedural, and what would be the relevant post-procedural concerns before we decide on a particular technique for the anesthesia. So what are the pre-procedural concerns we have to keep in mind? When a patient, a morbidly obese patient, comes for anesthesia, we have to know what type of procedure he's undergoing, whether he's undergone any similar or different bariatric procedures before, which could affect his anatomy and his aspiration risks. And obviously, these patients will have extensive comorbidities. They have to be evaluated. Now, these include simple ones like coronary artery disease, obstructive sleep apnea, hypertension, diabetes, and so on, but also specifically GI concerns. Now, what do I mean by that? Well, obesity, people say different things. Some people say it carries an increased aspiration risk because the gastric volume is more than 25 cc and the pH is less than 2.5. But there has been a landmark study which said that morbid obesity does not increase the risk of aspiration in day surgery procedures. So which one is right? Well, there's been like a multiple number of studies which have come across, and probably the consensus is that there is variable risk, but definite risk in obese patients who have long-standing diabetes or severe diabetes, which is uncontrolled, and or gastroparesis. So if these are the concerns, then definitely think that there's a higher aspiration risk. Okay, now let's come to the brass tacks. What are the most important things that we have to think about when we plan our anesthetic technique? What are the respiratory concerns? Well, we all know that when a patient is obese, their lung volumes, the FRC and ERV, will decrease, and they have a higher baseline respiratory rate, more metabolic requirements, more oxygen is needed to supply all the fatty tissue, and hence greater oxygen requirements, greater carbon dioxide production. They also have a heavier chest and a greater chance of a VQ mismatch. So, most important concern, after you induce the patient may become apneic, and this might cause significant desaturation pretty fast in obese patients. And more importantly, also, even if you give oxygen, the SpO2 recovery may also be pretty slow. So those are my concerns, okay? I'll keep those at the back of my mind. But what are the cardiovascular concerns? Well, there's a 10-fold increased risk of hypertension, diabetes, and coronary artery disease. But the most important thing, which is running at the back of our minds when we plan for sedation versus GA, is obstructive sleep apnea. So sleep apnea, especially long-standing, can cause significant pulmonary hypertension, and this can also be associated with like cardiomyopathy because of ventricular dilatation outpacing ventricular thickening. So this causes something called as obesity cardiomyopathy. And that could be pretty detrimental when a patient goes under anesthesia, be it under sevoflurane or propofol. So we have to do a thorough evaluation of all these risks. Comorbidities must be ascertained, and sometimes it's difficult to ascertain them because you'll see the patient typically coming in and saying, would you be able to climb up 2 flights of stairs, or would you get winded? Oh, definitely I can climb up 2 flights of stairs. It's just that my knees hurt, so I have to go really slowly, but I don't think I'll be winded. With that, it's probably kind of like concealing the actual problem here. So hence, sometimes you might need a further evaluation with functional capacity evaluation with a preoperative also in addition, also a preoperative EKG, an echocardiogram, and if needed, a stress echo. So you might think, why all these? It's just a simple low-risk procedure. It doesn't really fall against the algorithm, does it? But these may be longer procedures, and these patients are sicker. So we have to make sure that we have a full ascertainment of all the comorbidities before they come in for the procedure. Okay, so let's consider some of the other concerns. So now we've ascertained the cardiovascular and the GI concerns, especially the aspiration concern. And now comes to decision time. Should we go in for MAC or should we go in for GA? What do you think? Well, remember that whether we go in for MAC or GA, when the patient is super obese, with obstructive sleep apnea, there's a lot of redundant pharyngeal tissue there. And when the redundant pharyngeal tissue collapses, even if it's be partially during spontaneous ventilation, this will create a negative pressure. And with a partial obstruction, there's more chances of secretions, and you already have an unprotected airway. So all these factors have to run at the back of your mind. Mask ventilation may also be more challenging because you're sharing the airway with the endoscopist, the patient is in a weird left lateral position. And also, you can't just ask the person to pull out the endoscopy scope when you land into problems. So that's really important. One more thing, which specifically metabolically for these patients, is that these patients have a leptin insensitivity. So how does that matter? Well, leptin will actually control the ventilatory response to carbon dioxide. So there's a diminished ventilatory response to carbon dioxide, which we all know because the apneic threshold is shifted to the right. And this means that many anesthetic agents, benzodiazepines, narcotics, can actually accentuate this shift, and hence many of these patients have a very diminished response to carbon dioxide. They may not breathe for quite a long time, and during this time they might desaturate. The obesity hypoventilation syndrome is also distinct from OSA. This is completely unpredictable sometimes, a diurnal variation in ventilation, which might be very difficult to manage. So you do need expert assessment with probably a sleep therapist prior to the patient going in for the procedure. And many of these times, these patients are on a CPAP. So you might have to plan either extubation to a CPAP, or you might have to consider that the patient might need a CPAP immediately afterwards. But then many bariatric procedures, for example, if you do a sleeve gastroplasty, it's sometimes risky to give a CPAP with freshly placed sutures. So there are like so many factors which you have to consider when you choose your anesthetic technique. What are the other GI specific concerns which I have to consider when I'm making the whole anesthetic plan? I've considered about the patient morbidities. I've considered about certain procedural risks. Now let me consider about certain intra-procedural risks which will modify my choice of technique. So carbon dioxide and air can both be used during insufflation. What do I mean by insufflation? Where are they insufflating? Well, the endoscopist actually has a separate channel through which they actually give carbon dioxide, and this carbon dioxide goes in and it helps the endoscopist to see inside the bowel, the ampulla, everything much more clearly. And during sleep procedures, as well as during pose and rose procedures, certain types of bypass, endoscopic bypass procedures, you need more carbon dioxide. So you're going to continuously insufflate, and some of it is going to be absorbed and has to be eliminated by the patient. So when you consider a spontaneously breathing patient, that work of breathing has to be done by the patient. And if he's not capable of doing so because he has restrictive lung disease or severe COPD, you might land yourself into trouble because you didn't anticipate that. Hypercarbia also causes significant sympathetic stimulation. And you'll see in a case which I'm later going to show you, the end-tidal carbon dioxide went up as high as 56. Now that, if it's going to cause, like tachycardia and hypertension in patients who already have pre-existing coronary artery disease, you could have demand ischemia. And hence, all these things must run to your brain before you plan for the technique, because then you could plan for a GA, make sure that you have hemodynamic stabilization and the ability to actually ventilate it off. So these factors will make you a better anesthesiologist if you anticipate these and prepare for these factors. Simple drugs, fentanyl, we give that every time during a procedure. But how many of us really sat back to think that fentanyl can actually cause an increase in the sphincter tone? And in fact, sometimes residents give fentanyl kind of late because they thought they're matching it to the the time when there is maximal procedural stimulation. So they didn't give it initially, they gave it later because they thought like maximum stimulation is later, so let's give it a tiny bit later. But fentanyl causes sphincter spasm. And what happens is that now the endoscopist is unable to cannulate the sphincter or the ampulla vata to get into the bile duct. So the whole procedure is now in jeopardy because we gave the fentanyl late. So these are factors which have to run through your mind. So a common rescue method which is used by the proceduralist is to give glucagon. That'll cause sphincter relaxation. But glucagon itself can cause hypotension and tachycardia. So now you've landed yourself into problems by giving fentanyl late and then by having additional side effects caused by the administered glucagon. So hence, proper planning, proper administration, timely administration of drugs is sometimes really crucial in these procedures. So considering all this, is general anesthesia really easier for all these procedures? Well, that's a whole new section. because obese patients already have restrictive lung disease. They have baseline resting tachypnea. And mask ventilation might be challenging, intubation may be more so challenging. And moreover, it's like a small endoscopy room. Your machine is somewhere. The endoscopist is like looking over you and saying, are you ready? Are you ready? And then you're trying to mask ventilate and you want extra help in this. And the out of OR setting, you hardly have help. So it's going to be like pretty difficult sometimes. And hence, besides these factors, these patients tend to have a greater vacuum mismatch because they have more basal alveoli collapse, which is accentuated when, under general anesthesia, the diaphragm loses its tone, and especially with paralysis. Now, this coupled with decreased chest wall and lung compliance may make ventilation pretty challenging in these patients. And throw in the extra carbon dioxide, and you might find it sometimes very difficult to ventilate these patients. So you might also try to give more PEEP to splint open the airways, and then you might find that this is detrimental cardiac-wise. And hence, coupled with secretions and difficulty in ventilation, you might land yourself into soup. So carefully think about all these conditions and how to prepare and treat them if they happen, and then choose your technique. Besides just the airway concerns, we have other concerns when these patients go in for general anesthesia. Remember, or even MAC. They have to be positioned properly. They have a lot of sagging skin. Sometimes they're more prone to developing nerve injuries because of improper positioning. And many times you've noted that during the procedure, the endoscopist says like, oh, lean the patient forwards. Can you put the patient on the belly? Can you turn the patient to one side? Can you apply pressure to like the right upper quadrant? So you end up like in a weird position. The patient is like in a completely twisted up position and you don't know where the hand is, where the ulnar nerve is. So you kind of land yourself into problems. So always think, what are the concerns, and keep evaluating them throughout the procedure. So what about dosages? Well, dosage considerations in the obese are completely different, but they're very easily tackled. Lipophilic drugs, such as benzodiazepines and barbiturates, their volume of distribution is increased. And also, so is their clearance. So how do you change it? Use ideal body weight. What about less lipophilic drugs, like the neuromuscular blocking agents? Well, the volume of distribution is increased, but proportional to the lean body mass. So use ideal body weight and 20%. What about succinylcholine and propofol? Very unique. No change. Use total body weight for dosing. And what about Tylenol? What about acetaminophen or paracetamol, as it's called in Europe? Well, the volume of distribution is largely confined to the central compartment, which means since clearance is also increased, don't change the dose, but consider increasing the frequency if analgesia is inadequate. And that's something which we don't think. We always think like, oh, it has to be Q6 hours. But sometimes you might consider it being a little more frequent if the dosage is appropriate for the weight of the patient. Okay. So let's get down to the root of the matter. Let's consider the endoscopic, bariatric, metabolic therapies. What are the different types of therapies? Well, we have primary obesity surgeries, and then we have the revisional bariatric surgeries. The primary obesity surgeries are, it's very simple, the first one, primary obesity surgery, endoluminal. And then the second is endoscopic sleeve gastroplasty, which is one of the most popular ones. And then there are certain simpler ones, like the intragastric balloons, the Aspire Assist device, and one which is really popularized by Johns Hopkins, actually, gastric injection weight loss therapy. So the revisional bariatric surgeries are usually done in those patients who have already undergone bariatric procedures, but have failed them. They've again gained weight following many bariatric procedures and now want the anatomy slightly revised to help them with their weight loss, but are unwilling to undergo surgeries again. So many of them would be transoral outlet reduction, the Rose procedure, which is kind of similar to the primary metabolic procedure, wherein it's again an endoluminal obesity surgery, but restorative, and then a less common one, a sleeve and sleeve revision. In our institution, we mainly do the transoral outlet reduction and Rose procedures as revisional bariatric surgeries, whereas most of the primary obesity surgeries are done. So let's kind of look at them really quick and the anesthetic concerns for these. So primary obesity surgery, endoluminal. It's like the endoscopic equivalent of a Roux-en-Y gastric bypass or a sleeve resection. So we use a specific platform, which is called as the incisionless operating platform. It's nothing but a device which actually serves as a platform in which it carries the plicating device. So this serves as a conduit through which the G-prox, which is a sort of a stapling plicating device, is passed through it. So this is endoscopically placed into the stomach. The G-prox is placed through it. And then a belt and suspenders approach is used. Now, what do I mean by that? What is a belt and suspenders approach? Well, a belt and suspenders approach is basically an approach wherein both longitudinally and circumferentially the size of the stomach is reduced. So sort of like a belt and then suspenders pulling the stomach together. And hence, the final gastric volume is significantly reduced. So this is a procedure which could radically decrease the stomach size without having the patient to go under the knife, and hence is quite useful.
Grasp is removed and the needle is
a brief
then pulled
intro
back
into
and
the
the distal
procedure.
tissue anchor is released. These two snowshoe tissue anchors are then pulled together,
So you see here,
plicating the tissue.
the endoscopist is using the
Sutures then
plicating
cut and
device
released.
to cause
We'll now
full-length
see the
plications.
endoscopic image. Again, tissue is acquired by the helical grasper. This is pulled into the G-prox device, which has a relatively horizontal orientation. The jaws are closed, approximating the tissue. Needle is passed through the tissue, and the distal tissue anchor is placed through the needle. Jaws are then opened, and again the proximal tissue anchor is released. These are pulled together with serosa
The anchoring
to
device is
serosa
placed together
apposition,
to finish
as
up
this
the
is both
plication.
Grasper is removed.
So the second procedure, which is also sort of an endoscopic bypass procedure, but similar to the pose, is called as the endoscopic sleeve gastroplasty. It's very similar to the pose except that we use sutures. The same kind of longitudinal and sometimes circumferential sutures are done to reduce the gastric volume. Now, both these procedures, what are the concerns? They do require general anesthesia. Why? Longer procedure, sometimes several hours depending on the difficulty. And also, there is a risk of aspiration as well as bleeding in these procedures. Many times, the pain postoperative is pretty significant and may require at least observation for several hours. But most of the times, the endoscopic sleeve gastroplasty can be done as a day procedure unless there are any complications which require overnight or admission into the hospital. So, what are the complications which can occur during these procedures? Obviously, we have to secure the airway because there's a risk of aspirating and the risk of significant bleeding, which can happen. But most of the time, the bleeding is amenable to suctioning and securing hemostasis. So is there anything else significant which we have to consider for these procedures? You see here, there's a significant decrease in the lumen size. And it looks like hemostasis is being secured, but it can bleed later. But also importantly, CPAP has been used after laparoscopic gastric sleeve procedures, but whether they cause the sutures to be opened up when they are endoscopically placed is uncertain. So if you're going to have a patient who needs a CPAP, you have to use caution or at least observe them postoperatively when this procedure is done. And another thing is during the procedure, there can be a carbon dioxide leak. Now, what do I mean by that? So you'll see that in this procedure, if you see in the center, there is a syringe which is like so akin to a tension pneumothorax syringe, and you'll see that the carbon dioxide is actually bubbling through it. Now, what exactly happened? Well, if you look on the right side, this is a case which I actually did, and you will notice that the end-tidal carbon dioxide is pretty high at 56. And though the peak pressure is only 28, the starting peak pressure was actually 19. And it rapidly rose to 28. So how did this happen? Well, while they were doing the procedure, remember that they take full thickness sutures or full thickness plications. And sometimes at the gastroesophageal junction, there can be small, tiny holes through which the carbon dioxide escapes into the peritoneum. And sometimes even the stomach itself can distend pretty extensively to cause significant abdominal distension, and this causes increased peak airway pressures and can cause also increased end-tidal carbon dioxide. And sometimes the only way, if you notice, you'll see the sympathetic stimulation also, which is because of the hypercarbia. Surprisingly, the heart rate was not high because the patient was under metoprolol. But you will notice that the carbon dioxide has to be vented sometimes in order to reduce the distension and to improve your ventilation. And hence, these are complications which can occur under an endoscopic sleeve gastroplasty or even a post-procedure, and hence, sometimes general anesthesia may be completely mandated, and this is something which we should watch out for. So let's go to the next device, intragastric balloons. There are two types of intragastric balloons, which are FDA approved or in the process of approval. These are Orbera and Endobarrier. When I say Endobarrier is an intragastric device, I'm actually kind of pushing the truth. It's actually a sort of a film which goes into the small bowel and acts like an artificial Roux-en-Y bypass, meaning it covers the small bowel and prevents nutrient absorption, and hence there is no absorption of nutrients and the patient actually loses weight. So sort of like an artificial bypass system. Orbera, on the other hand, is an intragastric balloon, meaning that it's actually put inside the stomach, and insertion is very easy. It's just a small, thin balloon which is put inside, and it can be easily done at a MAC. And then the balloon is inflated, gradually inflated, so that not to cause extensive discomfort to the patient. But obviously, we want the patient to be completely NPO. It's almost like a 2-day colon prep. They have to be on a liquid diet for 48 hours prior, and they have to be NPO from at least the previous day. So this gradual distension has to be done very gradually, and like we have to keep on titrating the anesthetic to make sure the patient is comfortable. So while it's inserted under MAC, sometimes when it's being removed, it can cause a significant leak of fluid. There can be as much as 1 liter inside the balloon, or even more, and hence a huge amount of fluid gushes out when you puncture the balloon, deflate it, and remove it, and hence general anesthesia for removal is mandatory. Now, why is this important? One of the side effects of intragastric balloon placements is nausea and vomiting. And many times these patients land up in the ED with significant nausea and vomiting. And hence, you might actually end up in this situation on an emergent basis. And they'll come with significant nausea and vomiting. You'll be like, oh, is it small bowel obstruction? No, they had an Orbera balloon placement earlier, so it has to be removed. And then this has to be managed by the general anesthesiologist who's on call. So the balloon may also migrate into the small bowel and actually cause small bowel obstruction as well. It may even deflate and leak suddenly. So these are all side effects which are possible with Orbera. Our experience with Orbera is that a lot of patients have the side effects of nausea and vomiting, and we've started doing less of these, and we are more with ESGs and post procedures. What about the Aspire Assist? This is a very simple device. I would never think of anybody voluntarily wanting to put a peg tube, but apparently it happens. This is like a peg-like device, which is actually placed inside the stomach and can be done at a MAC, just like any other peg placement. And the patient has a small system, which is this system, and they have a reservoir and a drain tube, and they can drain out their stomach contents after a meal. It's actually pretty successful. It causes a 20 to 30 pound weight loss over 3 to 6 months. And then after the desired weight loss is attained, the peg can also be removed under MAC or under local. So the only thing is that if the peg is left in place because the patient has lost a follow-up or they didn't take care of the device, then it kind of gets stuck to the stomach wall as well as to the skin or the subcutaneous tissues, and it might require removal under general anesthesia. So that's one thing. Okay, so this is one of the latest techniques for weight loss. It's called gastric injection weight loss therapy. It's actually popularized in Johns Hopkins. To be honest, we don't do much of this, but it has been thought that we might introduce this more. It's an off-label use of Botox. It's very popular in some of the Middle Eastern countries, and even in India where I used to work. It's actually more popular because we use a lot of off-label things there. So there's an off-label use of Botox. Botox is injected into the muscle, stomach muscle in the antrum of the fundus, and it induces slowing of contractions of the muscle. So it sort of induces a gastroparesis. So they have early satiety and they lose about 20 to 30 pounds over 3 to 6 months. It's pretty simple. You can have repeat procedures done under MAC if needed. But for the best possible results, as with any other bariatric procedure, it must be coupled with exercise and nutritional and visual dietary changes. So those are the primary obesity surgeries. Now let's consider some of the revisional obesity surgeries. What are those? Well, they are indicated in patients who have weight gain, status post-bariatric surgery, and now are looking for non-surgical options to help them with weight loss. These are transoral outlet reduction, restorative obesity surgery endoluminal or the ROSE procedure, argon plasma coagulation or the APC procedure, and the GATE procedure. Well, the GATE procedure is not exactly a procedure for weight loss, but many patients, status post-bariatric surgery, end up with stones in the common bile duct or even more distally. So how do you access that, the common bile duct after a gastric bypass? It's very difficult to go into the duodenum, right? So this GATE procedure is a unique procedure, which actually just means gastric access temporary endoscopic. What do I mean by that? There's a small connection which is between the created gastric pouch and the older stomach, and then a small stent is placed so the endoscopist can go through that into the older stomach and into the duodenum and basket out the stones. And then after some time, the stent is removed, and then maybe a catheter should be placed to make sure that there's no leak. And then we can come out and make sure that the anatomy is again restored. So this is a really unique procedure, and we do a lot of those for CBD access for stone removal status post gastric bypass. Definitely requires GA for this procedure, can be much more longer and can be a little more painful postoperatively. Now, let's consider the revisional bariatric endoscopic procedures. The main one would be transoral outlet reduction and the ROSE procedure. Outlet reduction, the name says it all, honestly. So there is an anastomotic dilatation which happens, like maybe because of improper dietary habits or just because of lax muscle after bariatric surgery. And the idea is to kind of squeeze it back to immediate post-bariatric sizes. So initially an endoscopy procedure has to be done with specific measurements to find out what is the size of the anastomotic pouch entry. And then we have to make sure that we reduce the size. Again, we use the Apollo endoscopic suturing platform, and we suture the area in sort of a purse string fashion to decrease the size of the opening. Has to be done under general anesthesia, can be a little painful, can be a little intense, and post-operatively we can have significant nausea and retching. So all these are the considerations that we have to keep in mind when these patients go in for these procedures. Restorative obesity surgery endoluminal, very similar procedure. Again, the size is reduced, but similar to pose, we use those plications with anchoring devices to reduce the lumen size. Similar concerns for both ROSE as well as the TOR procedures. What is argon plasma coagulation? It's actually a relatively simple procedure. You just apply laser to the anastomotic opening to decrease the size, and it can be done in simple short bursts, meaning 15 minutes and you're done. Whether you'll get a complete cicatrix formation and basically like decrease in the lumen size with one sitting is not obviously possible. You might need multiple sittings and multiple evaluations of the scars to make sure that the scar has reached the final size determined. But simple procedure, day procedure, they come in just like a regular endoscopy, have this done and go back. But remember, if they already have significant reflux, if they are able to lie flat, or they have like really bad symptoms when they're actually going in for the procedure, it may not be possible to do it under MAC. So what are the complications which can happen after bariatric surgery, which are dealt with endoscopically? So these are complications which happen after regular bariatric surgery, but they are dealt with endoscopically. So let's consider some of these options. Well, complications. And what are they? Well, UGI bleed. Sometimes there can be leftover suture material. The sleeve can undergo stenosis like we just saw with all the revisional bariatric procedures, or there can be an absolute GJ stenosis which can happen with Roux-en-Y bypass. Metabolic complications. Obviously, there'll be electrolyte and nutrient deficiencies which happen after bariatric surgery. And that's what is anticipated. But we've got to know them to anticipate them and help treat them. Ulcers are one of the most common complications, especially anastomotic ulcers, which happen in older patients with ischemia to the site. And they are also easily treated. So the most dreaded complication is a massive UGI bleed. If it's minor, actually a quick endoscopy to find out the source of bleeding can actually be done at a MAC. Or even you can find out a source of bleeding if it's a microscopic bleeding only detected by a drop in crit or melena. It can be done as an IR procedure, an interventional radiology procedure. You can do a nucleotide scan to find out the site of bleeding. And many of these procedures will require little to no sedation. But if it's a massive bleed, obviously, we have to secure the airway, large bore access, volume replacement, maybe an A-line monitoring, intraoperative octreotide, the whole works have to be done. So what are the complications which are also treated after bariatric surgery by endoscopy, other than ulcer and a UGI bleed? The most important would be stenosis, which we already saw, anastomotic dilatation, which we saw, and stenosis. The main thing is that you're treated by what is known as an axios stent. Now, the axios stent is almost like manna for the endoscopists. They seem to be using it for everything. You'll be like hearing this slipping off their tongue like many, many times. And if you like at least kind of know what it is, you can appear very knowledgeable, which is very nice. So the axios stent, even if it's for a fistula placement, they use it. If it's for a drainage collection to kind of like decrease the size, they use it. For stenosis correction, they use it. It's basically like a mesh which can contract and also allow drainage. So it's very, very useful. But for the same reason, when it's placed, it's pretty stimulating and there can be considerable drainage of fluid when it's placed. And it's opens up the collection. And hence, GA is necessary for axios stent placement. When there is an anastomotic dilatation, we saw that suturing is done. But when there's a stenosis, you can treat it with balloon dilatation, which also may be stimulating, or you can place the favored axios stent. Now, when there's a leak, there's often a pigtail catheter which is placed. But this pigtail catheter, which I've shown in this picture, sometimes it has to be serially downgraded with repeat procedures till we can make sure there's no leak. And the initial leak may be pretty significant and may require GA initially because the leak is pretty significant and you have to take aspiration precautions and also to evaluate, while evaluating there might be bleeding. But subsequently, as we downgrade, you might be actually able to shift it to MAC. So all these considerations should run in your mind, and a thorough sort of discussion with the proceduralist is really important when you consider what anesthesia to give for these procedures. A Bezoar. Now, honestly, I don't ever think much about Bezoars till I read Harry Potter. But Bezoars are basically stones which happen inside the stomach, not necessarily of a goat, which is said there. But these Bezoars have to be broken down because it's very difficult to basket them and take them out with jet fragmentation and drilling. And obviously that sounds like a GA procedure. So all these complications of the bariatric surgery, which are so dreaded, which were like so much fear-inducing in these patients before, can be easily treated with endoscopy now. But it's up to us to be aware of those so that we know what you're dealing with and how to prepare for them. So how does this actually work postoperatively? Now, some of the important things which happen are total body hormonal changes. When I say total body hormonal changes, actually I mean really outside the GI tract as well. Now in the GI tract, there's so many hormonal changes. I've just listed them there, but basically they eventually come down to vagal denervation, decreased hunger, increased satiety, and even an alteration of the gut flora, which is so important for some patients. And otherwise you'll notice that many of these immediate postoperative patients have a lot of farting, a lot of burping, with no changes in the anatomy afterwards. but slowly it disappears because your gut flora also changes to like a favorable picture. And now they've noticed that subclinical hypothyroidism changes, their leptin levels change, their response to ventilation changes, and they've also noticed, or so my sister who's a gynecologist says, that IVF is more successful in these patients after bariatric surgery. And it's not just because of weight, even in a 22-year-old who will otherwise rapidly become pregnant, when they undergo bariatric surgery, the hormonal mechanisms change, even in the adrenal axis and the gonadal axis, that they have a greater chance of becoming pregnant, but they have to wait for 12 months. So what are the other anesthetic concerns post-bariatric procedures? When these patients come in for procedures after bariatric surgery, and many of these patients do. You've seen like many of these patients come in for plastic procedures after bariatric surgery because of your sagging skin, and you'll be like taking care of them in the OR as well. And you have to reassess your airway, obviously. The sagging skin can cause nerve injuries. And these patients actually have a lot of electrolyte abnormalities. They can have hypocalcemia, which can cause muscle weakness, arrhythmias, and change your response to neuromuscular agents. They can also have hypokalemia and muscle weakness, and also arrhythmias. And if you have a pacemaker, that's also going to be altered. They can have a significant vitamin D deficiency. They have to be on supplementation, but more importantly, that can decrease healing and also your immune response. And they can also have B12 deficiency, which can cause significant neuropathic pain, which is otherwise not really amenable to treatment with narcotics. So all these have to run through your mind when these patients come in for procedures. So this is the important thing which I want to share with everybody. We've done plenty of studies, and we found out that patients who've had Roux-en-Y gastric bypass are actually safe for IBCS or nursing sedation as well, and not just MAC after the procedure. Most of them do not have significant reflux or other complications that would mandate us taking care of them versus nursing sedation. And this is important because in many patients, like especially endoscopy centers and so on, the cost is different. But somehow they have found out that Roux-en-Y gastric bypass patients, even if their weight decreases, they have higher dose requirements following Roux-en-Y gastric bypass. And this is like if you match controls, Roux-en-Y gastric bypass patients with similar age, gender, and BMI, they seem to have higher doses required. And patients who also underwent EGD before and after Roux-en-Y gastric bypass, their sedation requirement increased. Now, how is that possible? I mean, their weight is dropped, so why would they require more sedation? It doesn't make sense, right? No. Apparently, most of these patients have improved steatosis, hepatitis, fibrosis, and even cirrhosis improved in about half of the RYGB patients at 2 years. And the improved hepatic metabolism has resulted in improved clearance of fentanyl and midazolam, which is most commonly used in nursing sedation. And this has resulted in increased requirements of these patients when they go in for EGD with nursing sedation or IBCS after Roux-en-Y gastric bypass. So that was something which was very surprising for us when we did the study. And the same patients, actually, we discussed their requirements before and after, and we found that it was actually increased. So that's something which we have to keep in mind afterwards. We think that they've lost a lot of weight, that the requirement is going to come down, but it may not be. So in summary, obesity carries many risks, and endoscopic surgery also carries many risks. Both have to be carefully evaluated before you determine what your anesthetic plan is going to be. A very thorough preoperative assessment might be necessary, and lab work, investigations might be necessary, even though this seems like a low-risk procedure. Care should be taken by us to note what type of procedure, discuss it with the endoscopist, and think about all the risks, not only aspiration. And then lastly, remember that we're going to use carbon dioxide insufflation, coordinate with the GI physician, watch for ventilatory parameters throughout the procedure. And that's really, really important. So in conclusion, an endoscopy is never just a simple endoscopy till it's actually finished. Please coordinate with the endoscopist. Listen to what they say. I mean, it's very easy to think that they don't know much about anesthesia, and it's very easy for them to think that we don't know much about the surgery, but it's really important that we coordinate so that we both anticipate each other's procedural risks and hence make for an optimal preparation and a safe patient. I have to thank Dr. Bazarbashi and Dr. Chris Thompson of the department. They really helped me with understanding some of these procedures and the videos. And thank you very much for this opportunity. Thank you.
Fabulous talk, Lalitha. Thank you so much
Thank you.
for visiting Johns Hopkins, even if it is virtual. Wow, I go down to endoscopy, and so all the things you said hit home for me.
Steve, it's hard to hear you a little bit.
Oh, okay. How about now? I'm not on mute. Can you hear me?
We can hear you. It just sounds like low volume.
Okay, I'll speak up. So, how about now? Is this better?
Yep, just go with it. It's good.
Okay. So we have a lot of comments, not many questions from someone named Nala. I don't know who Nala is, whether she's from the Brigham or from Hopkins. But a lot of comments, and they all seem to say we should use general anesthesia. If in doubt, use general anesthesia. And that brings me to my question and comment, and that is, I like your Shakespeare quote, to intubate or to not intubate, that is the question. That was great. So you use the term MAC or GA, right?
Yeah.
And that's always the question, MAC or GA. But I would contend that MAC, as we're calling MAC, is really general anesthesia. You just don't have an endotracheal tube, because at the doses of propofol that we're giving, we all know the patient is unresponsive to pain. And I did a small study where I put the BIS monitor on 10 consecutive colonoscopies, getting straight propofol sedation, quote unquote. And the average BIS score was 30. So, and they had, nasal cannula, oxygen, and so I'm sure we all pretty much agree that 95% of our patients are getting general anesthesia. And so to intubate or non-intubate is the question. And are you leaning more towards intubation? The more years I do anesthesia, the more likely I lean towards intubation.
I agree, Dr. Frank. It is total IV anesthesia rather than MAC. It's more about protected versus unprotected airway. But as I said, for most of the procedures like gate, pose, rose, and we've largely given general anesthesia. And for APC, many of the times these patients are done under nursing sedation. And they only come to us because of other comorbidities. And then it actually becomes total IV anesthesia, I think. But for the pigtail leaks, we've largely erred on the safe side and we've given general anesthesia. Also because many times there's not like complete continuity of care. And we've seen that the large anesthetic is general anesthesia. So we kind of like give general anesthesia just to be on the safe side. We don't think about downgrading the catheter, like whether the leak is less and therefore the risk is less. So most of the times we do err on the safe side, and we do give general anesthesia for the pigtail leaks. And for the other procedures, only because of the risk of plausible bleeding, and the procedure, when it's done by the fellow, it's much longer. So we end up giving general anesthesia. But technically, if Chris Thompson or somebody who's very experienced is doing the procedure, we usually coordinate with them, and if he says it can be done under MAC, or IV, total IV anesthesia, we do prefer it.
Nice
Just for
summary.
time concerns and for proceeding.
So Nala wrote a comment, if we can give our comments. So feel free to unmute yourself, Nala, and give your own comments and tell us who you are, if you will.
Okay. Thanks, Stephen, and thanks, Lalitha. It was a wonderful lecture.
Thank you.
Well, I work in Dubai.
Okay.
And I work in a hospital which is one of the centers of SRC recognized Center of Excellence in Metabolic Surgery and Syndromes. We've been practicing this for the last 15 years, and we have extensively gone into endoscopic procedures for the last 10 years. And we have gone through all whatever you have described. What I wanted to share was few things. Like you rightly said, why don't you take the patient on a lateral position when you're going to do your sleeve procedures, which is done in a lateral position. So I do intubate all my patients only on a lateral position, which is very comfortable with a glide scope. And we do always a nasal intubation, which I've been trying to emphasize to in every conference I go. I've been doing this in the last 10 years. And I was surprised because let's be clear, this is going to be a 1 hour procedure, a half an hour procedure. A nasal intubation is not going to be dangerous if you practice it in the right way. The second point is, it gives an enormous passage for the surgeon because as you rightly said, the endoscopic bariatric procedures involve a lot of airway manipulation. They use big trocars, the entry devices, everything is quite a bit of it. So and very fact, the right you said, I tell my patient to just lie down on their side and then just be comfortable. And once they're comfortable, you just induce them and put the tube through the nose. And that's it. Now, the most big advantage that you rightly said was obstructive sleep apnea, recovering the patient from anesthesia. You just pull off the nasal tube and leave it as a nasal airway. You can give a CPAP. So I've practiced this for the last 10 years. And I'm honestly telling you, I've never had all these problems of people talking of bleeding. Come on, the surgeons make more bleeding. They go everywhere, and when they enter into the esophagus, they can damage every mucosa of the esophagus. They create bleeding. So why should we think our bleeding is going to be a big problem? It may be 1 in 100 or something like that. So I just wanted anesthetists not to get into that fear. If you pass the tube through the nose, you may damage the septum, you may damage the adenoids, you may create a bleeding. No, it's not like that. And I honestly feel that it's so comfortable. And the most comforting thing is when you come out of anesthesia and when you extubate all your sleep apnea patients, you just have to pull out the tube and leave this cut. I cut the tube off at the Portex mark, which is just enough to be as a nasal airway, and they're still comfortable. And the other important point was what rightly you said, inserting balloons and small procedures can be done by MAC. Removing a balloon is not a joke. It can be a nightmare for everybody. So that's where we made it mandatory that every balloon removal will be always a GA. Balloon insertion will be a MAC. There are a lot of procedures which are done in MAC. We also do a lot of procedures under MAC. But the other very important point which I wanted to share with you was about the stent placements. We have found that post-gastric, the leak patients with stent, sometimes it's very annoying. The pain that they suffer is so bad that I've been unable to take care of it. And sometimes we had to remove the stent the following day, having placed it. And we do a lot of pigtails as well. Pigtail is a very tricky job. It can, the surgeon may say it's 5 minutes. It can go up to 1 hour, 2 hours.
No.
So I think what you rightly said is that you need to judge each patient as they are. And it needs a lot of patients to go through them, not to take it lightly because it's going to be in an endoscopy room. No. It's a challenge. And being out of the theater, I've been doing this for the last 10 years. We have developed a lot of protocols and we've been quite comfortable. And we always do a relaxant anesthesia because now we have rocuronium and Sugammadex, so there's no problem. So why should we keep them on spontaneous or something like that? You can always get them out and quickly and get them back rather than struggling with the surgeon, the sphincter and all these things. It was a lovely talk and I'm very happy that I could share some of my points. And we also practice most of what you have been talking about. And thank you for this opportunity.
Nala,
thanks.
Thank you, Dr. Nala.
I want to leave time for other people to ask questions.
Thank you.
I do want to know, you said you practice in Dubai, Nala. Were you invited through Harvard or Hopkins by the email?
Oh, I think I sent an invite to my
From a
friends.
Jipper club.
Oh, good.
We
Yeah,
are all Jipperites from India.
Wonderful.
from my alumni in India.
Truly an international audience. I love it.
We love it.
Anybody
you.
else have questions before we've got 4 minutes left in the hour? If not, I have a question. But thank you, Nala, for all the insight. Sounds like you have a
That's
lot of experience.
that's a nice idea. I never thought about the nasal cannula being actually used as a. So you've never had any problems with CPAP with endoscopic sleeve gastroplasties afterwards?
Absolutely. Honestly, true. I'm talking evidence-based medicine. I don't know about there's a lot of controversy on this. I've been practicing bariatric surgery as well. Even at 80 BMI, I do have a Prader-Willi syndrome patient right now in the hospital. Is a 16-year-old boy with 200 kg, 80 BMI, with a pulmonary artery pressure of 90. But one thing is for sure, a nasal airway, a nasal intubation has made a lot of things easier. So I don't know. I'm still waiting for a lot of the world to respond on that. I take this opportunity. Thank you.
Thank you.
So you mentioned with ERCPs, fentanyl may cause constriction of the sphincter, of the ampulla bladder.
Yeah.
I've never really thought about that. And do you try to avoid opioids for ERCPs for that reason?
No, sir. So I've had this mistake made many times in my cases. So like a new CA1 comes who's like in the out of OR rotation, and they come and they feel like, Mac, you should match it to the maximum procedural stimulation, and they kind of give it late, and it causes a prompt sphincter spasm. But the sphincter spasm only lasts for the peak action of fentanyl. So usually it does not last for more than 5 to 6 minutes after administration. So if you kind of time it, the analgesic effect will still be there, but the sphincter spasm will be much less. So, I would not give fentanyl, but I would just time it. And ERCPs can be pretty painful afterwards, actually, because of the gas being used. As I said, most times we use carbon dioxide, which is less painful. Air is much more painful, but sometimes you run out of carbon dioxide, or sometimes you get a better visualization with air and they end up switching to air intra-op. And then they have a lot of gas pain afterwards. And though, like fentanyl is not ideal for gas pain, it does help to abate it.
Yeah, they do have the most pain in the PACU of all the endoscopy cases that we do. Wonderful. One more question. This is a hot topic. Maybe you can give us a short answer. Do you do the same pre-op testing for endoscopy that you do for other patients having real surgeries? Because
I like the way you say real surgeries.
because we've for years we said, oh, it's just sedation, they don't need pre-op testing. But now we're really doing general anesthesia with intubation. Are you doing more pre-op testing?
We're doing the same testing as in the pre-op clinic. The assessment is based on the patient. So actually, we had a patient the other day who was status post TAVR, like a TAVR procedure from before, but they didn't have a recent echo, and they were like pretty symptomatic, coming in for an emergent UGI bleed endoscopic procedure. It's probably going to be under sedation because it's not like a complete bleed. But we did want make sure if you're going to do an echo, please do it in the morning so that we can actually do the patient in the afternoon. So it's probably useful to have that information, even though it's just a sedation procedure, because finally, if during the procedure you end up with more bleeding or some other issues, you got to be prepared. You got to know what you're dealing with. And that has also actually happened to us. One of the procedures, they said, oh, we can do it under MAC, no problems. And then they went inside and they actually disrupted a clot, and there was massive bleeding. And now we had to emergently protect the airway. We had to switch to general anesthesia in that tiny room. We had to switch around the patient. And it's always easier if you know what you're dealing with before we go in for the procedure. So many times the endoscopist can also be a little bit wrong. You can say oh, it's just a tiny bleed, but it may not be.
I want to add that the slide you're showing right now is one of my favorites I've ever seen.
I know, because we have to coordinate. This is like one area that we have to coordinate. And many times, I'll be honest, a lot of us don't know everything about some of the procedures that they do. Like when they say it's a gate procedure, when they say it's a TOR procedure, you'd be like, oh, okay, do I need to protect the airway or not? And they don't know what the complications could be. So if you kind of like interact better and kind of know about it, it's a better anesthetic.
Back to the Shakespeare question. Well, I think we'll wrap up so we don't run over. And thank you again, Lalitha. It was our pleasure to have you as a speaker.
Thank you, Dr. Frank. It was a pleasure to be here. Well, be here and be there.
All right,
Thank
wishing
you.
you all the best.
Thank you, sir.